Thank you, Dr. Mukesh, for inviting me to be a part of this wonderful IC. So I will get started. I will be talking about senile entropion and ectropion. So mainly, as the name suggests, these are due to aging changes, usually in the lower lid, and maybe unilateral or bilateral. So let's understand the anatomy of, is there a pointer? Excuse me, pointer? Okay. So let's understand the anatomy of the lower lid. The main support of the lower lid is the tarsal plate, which is not as well developed as the upper lid, but still it is a very important part of the support. And the attachment to the medial and lateral canthal tendons, which forms what we call a tarsal sling. This and the lower lid retractors are important for maintaining the position of the lower lid. The lower lid retractors are the capsulopalpebral fascia and the inferior tarsus muscle. So the aging changes are stretching, laxity of the lower lid retractors and the canthal tendons, lengthening and weakening of the lower lid retractors causes an overriding of the orbicularis muscle fibers, the preseptal over the pretarsal. Now, both the changes can cause either entropion or ectropion or both. It depends on which structure is more affected. So in the video we can see that the lateral and the medial canthal tendons are not affected. So they are in their position and the orbicularis just rolls over this lateral tarsal sling. So entropion is the predominant part of this patient. When there is only lengthening, the lid falls away from the globe and then you will get ectropion. And then sometimes when both the factors are there, there is laxity of the tendons and a falling away as well as the laxity of the retractors, you will get a combination of entropion and ectropion. So coming to entropion, the main problem is the weakness of the lower lid retractors, or there is a dehiscence of the septum causing the lid margin to roll in. Managing it is temporary measures are like taping, using lubricants, and sometimes like this lady had a spastic component just after surgery, cataract surgery, and there was a spastic component which we treated with Botox and she was fine. But the definitive method treatment of choice is surgical. So the principles of surgical correction is that we are working on the anterior lamellar structures. We need to shorten or tighten the lax structures and strengthen the weakened retractors. There are a number of procedures that have been described. I find the modified Jones procedure the simplest and the most useful. So I'm going to describe that. We are strengthening the lower lid retractors by plicating them or reattaching them. It can be a skin or a conjunctival approach. I'm showing you currently a skin approach. So it's a subciliary incision. You dissect down to the tarsal plate. And then you dissect till you can see the dehisced aponeurosis and the retractors. Then we reattach them to the tarsal plate. So this is a double-armed suture through the tarsus. We are plicating the retractor and the dehisced tissues. So we pass it through the tarsal plate, pick up plicate the tissues, and then come back and make sure that it is attached to the tarsal plate. And we tighten it. The correction is seen on the table. You see the lid is turning back, and then we can do two more on either side. So three sutures like this, so that we get a good contour and the whole lid along its length gets corrected. There's a correction in the whole lid. Again attach to the tarsal plate and then tighten. Now in this there is always some lax skin. So a spindle of skin needs to be removed, and depending on how much lengthening there is of the entire lid margin, you might need to either do a wedge resection laterally or a lateral strip procedure, which I'm going to show you in the next video. So in this case, after this we had done also combined it with a lateral strip procedure. Now coming to senile ectropion, again the pathophysiology is the same, but here there is more lengthening, more laxity, and this could be medial or lateral, and it's important to see how much this person had a combination. So you do the pinch test and you do the distraction to see how much of excess lid is there, so that you can plan to correct it. In most entropion they will be rounding of the lid margin, there's lengthening and sagging of the lid. So the lateral strip procedure, this is a very good procedure, entropion and ectropion, and multiply even in many other situations it is used. So you start with the canthotomy. You have to go down to the lateral tubercle. We need to attach our strip to the periosteum here, so important to go right down. Now you release, the lid is being released, so we cut the lower crust so that we can release the lid completely and then reattach it at the point that we want to reattach it. So then we split the lid margin. Now the lid margin is being split at the gray line. This is the most important step, where you have to separate the anterior and the posterior lamina, because we only want the tarsal strip to so that we can lift the whole lid. So we separate the anterior and the posterior margin. And now we are fashioning a tarsal strip. So this is the tarsal strip that we are fashioning. This is another important step, to remove the epithelium and the conjunctiva, because you don't want epithelium growing inside when you are burying it in the depth. So you remove the conjunctiva, you remove the epithelium. And then I'm using a 6-0 proline suture. You can use any other suture. It has to be a non-absorbable strong suture. So this, you need to get a good bite of the tarsal strip. You can do a doubled arm or as a loop, as I'm doing. So it's a good, because it's quite friable, the tarsus, so you need to make sure it is large enough and the suture has been passed well so that it doesn't break away. And now this suture has to be attached to the lateral, the periosteum of the lateral tubercle. And it's important to be deep over here and make sure it is a strong bite into the periosteum. Sometimes you need to use a more curved needle. Again, one bite more to be sure through the tarsus. And then we tie it here. This is, make sure that it is lifting the whole lid, and tie a knot down and make sure it is deep. That's the important part. It has to be deep, it has to be at the correct height so that it can lift the whole lid. Then there is some, after you've tied this knot, there is some excess skin. So that excess skin needs to be trimmed. So this is, you're trimming the excess skin. Since you have shortened the lid, there will also be some skin muscle that needs to be removed.
Dr.
So
ANITA, can you please sum it up, because we have started.
To summarize, You have to study the lid changes, note the amount of laxity, lengthening, look at the state of the canthal tendons and the retractors. You can choose any surgical procedure, you can combine them. The modified Jones works very well for Entropion. Sometimes you need to remove a triangular wedge as well, or combine it with a lateral canthal sling. Thank you.
Thank you. We can have one or two questions now, and then I think if time permit, we'll have a detailed panel discussion later on. So I'll ask you a question, like whenever you are doing LTS, like as you said, it can be done for both Entropion as well as Ectropion. So if you are doing it for Entropion and in turn you are getting some Entropion with LTS, so how do you manage to correct it with some modification in LTS, or any role of some sutures, augmenting sutures, if you...
Well, I do the Jones procedure first.
Along with the
I
LTS.
do the Jones procedure and then I do the LTS,
Okay,
so that I have turned it out and then I use
So
that
you
tarsus.
combine both
I
the
can
things.
combine both.
Okay.
But more often I do the Jones and then just do a little wedge resection laterally, and that also works quite
So
well.
it's a good idea to combine these procedures, otherwise LTS alone may lead to some amount of entropion.
Yeah.
The other thing which can be done is everting sutures. There are a set of people who combined LTS with everting sutures whenever it is being done for entropion. Thank you, Dr. ANITA.
Or if it is mild, you may just do a lateral canthopexy rather than just sutures for tightening rather than, they will also work well.
Yeah,
If it is more, then of course we have to do it LTS.
Yeah, so when you do the wedge, when I do a wedge resection, I do that laterally and then I just use the suture to tighten it.
So very nice.